So the clinical value of MRD negativity. So MRD negativity, what do we mean? It's a moving target, so it's not really negative. It doesn't mean that there is no CLL cell left in the body. It means that it's what we can find, what we can reliably assess to be present in the body. At the moment, we can reliably assess if there is one cell per 10,000. So below that, we are not able to see anything. So if we don't see anything, we don't know if because we don't see anything, because there is nothing, or because we are just simply not able. So this is the limit at the moment, 10 to the minus 4, 1 in 10,000 lymphocyte. That can be achieved with 4-color flow cytometry. That is the standard nowadays for also because it's easier, or PCR. The ERIC, again, I'm sorry that I'm bothering you always with the ERIC, did a lot of work, and we published 3, I would say, major papers starting in 2007, then in 2013, and now the last one has been published 1 month ago. First author always Andy Rostrom, who did most of the work, and we set the standard that at the moment is a so-called 4-color assay, where you have 4 antibodies with different colors in 4 tubes. So that means a certain number of cells that you need to acquire and analyze, and of course a certain cost. These are academic costs. These are not hospital costs that you have to multiply by 10 at least. Then we move to a 6-color panel, of course, less tubes, cheaper, less cells that you need. And then now in the last paper, we studied what we consider will be the next standard with 8-color, only 1 tube, easy, fast, and quick. The cost is, of course, half of the rest, and you need very few cells to do. What we learned indeed is that we don't need 8 colors, so we don't need 8 antibodies, so it's even cheaper now. And this will be the next standard with 6 markers. Here you can see the 6 markers, and that can be combined in 1 tube. And thanks to BD, who help us to produce really antibodies and conjugates that were not existing before, so we could do the right combination. And therefore we can go down to 10 to the minus 4 reliably, and probably even 10 to the minus 5. Why do we need to do MRD in CLL? Because at least a cohort level, a population level, it is known since at least 10 years that patients who achieve MRD negativity do better than those who don't. And this is true even if you use a single antibody. This was a study with Campat, with alemtuzumab. So regardless the therapy that you use, if you do achieve MRD negativity, the patient survive longer, progress later. So this is progression PFS, this is survival. Of course, this is true also if you use immunochemotherapy. This was the original study from the MD Anderson, and they show that indeed the patient with FCR treated with FCR reaching MRD negativity had a longer PFS and a longer overall survival, which does not mean that all of them are cured. So please don't get confused. We are just talking the fact that a deeper remission gets you longer progression, longer progression free. The study, the value of MRD then has been established once forever, I would say, at least for immunochemotherapy, by the CLL study comparing FCR versus FC, and where they show that again, you can achieve MRD negativity, 10 to the minus 4, less than 10 to the minus 4, with either combination. You get more MRD negativity with FCR, as you expect, rather than FC. But still, if you get into complete remission, MRD negative below 10 to the minus 4, then the progression-free and the overall survival is identical, regardless how you achieved your complete remission. That's the first concept. The second concept is also that if you do achieve only a partial response, but you are MRD negative, then your progression-free and overall survival is better. Why is that? This is a nomenclature problem. So the partial response is not someone who has still 2, 3, 4, 5 centimeters of lymph nodes, are patients who did not recover from, for example, neutropenia due to chemotherapy. So those patients are not officially in complete remission because they did not recover all their blood counts. So they are still in partial response, but of course, is almost complete response. Even with the chlorambucil, together with the right antibody, in this case GA101, we saw the data before, but if you stratify by MRD negativity, patients achieving MRD negativity status have a longer PFS compared to those who don't. So this is somehow now recognized by everyone. So there is an advantage in getting to MRD negativity, or what we can say to getting to a lower level of a more profound level of remission. So this is the idea. On the pathway towards cure, the deeper you go, the better it is. So we can look at MRD negativity as just a better clinical complete remission. So it's another way of looking at it, not only using CT scans, but also using MRD flow. So we can go even lower, of course, because this is not 0. So we can go down 10 to the minus 6. And that can be achieved with the next generation sequencing. As I mentioned before, it can be the future. And in this paper that we published, indeed, we already compared the flow cytometry versus high throughput sequencing, so a next generation sequencing. And as you can see here, it can go down 10 to the minus 6 in a very linear way, which is definitely better than flow. It is better than flow. And we compare that indeed with this is next generation sequencing. This was a collaboration with Adaptive Biotechnologies compared to MRD flow. And in some cases, we were able to, even if they were defined negative by flow, because there was nothing above 10 to the minus 4, then there were still cells that can be assessed by next generation sequencing because the threshold is lower, 10 to the minus 6. And so these patients were not indeed negative.
Paolo,
Yes.
So none become negative?
No, only these 4, the red one. No, some were negative by flow and some were negative also by
by sequencing. The first 4 you consider negative.
These 3 were considered negative by flow, but were positive by
exactly.
by
so my question is, do you find any negative?
No.
That's the question.
No. Okay.
So
far it was not true.
So you've had no cases negative by sequencing?
No, we found cases negative by sequencing.
Oh, you did find?
Yes. I understood that you asked me if we found negative by next generation and positive by flow. No. Yeah. But there were negatives by next generation sequencing. So again, probably 10 to the minus 8 or 10 to the minus 10, but we don't know. Yes, indeed. So why would we want to assess MRD? Of course, because that could be a surrogate for our studies for the PFS. And probably also for overall survival, because that's what we learned from the immunochemotherapy results. Indeed, the FDA started already, it's almost 3 years now, considering this. We had a meeting close to Washington. They were supposed to give a recommendation and to be included in the guidance documents for the next generation of trials. Nothing happened. In this time, EMA seemed a little bit quicker. So by June this year, they closed the consultation with all the experts in the field. And again, we are waiting for, we are expecting that they will publish soon a recommendation from about the next generation of trials. But again, this is not happening. Why is not happening? The point is the following. It is true, and now it's clear that the lower the remission, so the more negative is the MRD, and the better is the outcome of the patient. So these are different levels. 10 to the minus 4, 10 to the minus 3, 2, 1, 0. And so you relapse earlier if you have more disease. That's obvious. So this is quite convincing that MRD can predict PFS, but it's convincing in the terms that depending on the therapy that you did. So we know that it is true for single antibodies. We know that it is true for immunochemotherapy. We don't know if that is true with any therapy because we don't know how we are modifying the natural history of the disease with that particular therapy. So that's the major concern of the regulatory agency. So sometimes we criticize the regulatory agency. Most of the time, maybe it's good, it's right to do it. In this case, they are cautious and probably it's correct. Why is that? Because we have to keep in mind that it is true that the deeper you go, the better it is, but then it depends how fast you come back. And that might depend by the drug that you apply, but very likely might depend also by the biology of the disease which is underneath. So if you have, for example, a mutated immunoglobulin mutated CLL case, maybe you go down and you remain down. So we know that patients are probably cured even. But if you have a 17p deleted patient, we know that we can go down, get to MRD negativity, and then this patient after 6 months, they rebound completely. And then, of course, we have all the different other situations, maybe 11q, maybe unmutated immunoglobulin gene. So that really depends on the biology behind. And so whenever we are applying a new drug that is actually acting on the biology of the disease, then we don't know really what's going to happen. And that's probably the reason why the regulatory agencies say, okay, first show me that there is an association between MRD and PFS with that particular drug, with that particular combination, and then I can use it also in the next, for the next trial as a surrogate. But then in the next trial, you will not need anymore that surrogate, you will need it for another drug. So that's a point. Another reason to have MRD assessment would be, of course, to tailor our treatment decisions. We always think how to increase, how and when to increase treatment to achieve MRD negativity in the patients who do not achieve. I usually think how to decrease the treatment for the patients who achieve MRD negativity earlier, because that's also another thing to spare our patient from toxicity. And this is a study that I just want to show you by Paolo Strati at MD Anderson, just because Paolo was working with us in Milano before going to MD Anderson. And this is the first report that suggests the idea that maybe we could apply less cycles of SCR, at least in a portion of patients, because they show that in some patients who achieved MRD negativity after 3 cycles of SCR, they had a very nice progression-free survival that was identical to the patient who achieved the MRD negativity after 6 cycles. Of course, this was not a randomized study. It was the patients were selected and they stopped the drug based on the physician decision. So, of course, there are too many biases. But the idea is probably where we have to go. So probably to use MRD to decrease the burden of chemotherapy. And that's it. And thank you so much for your attention.
So one thing I've always had a issue with these kinds of studies, and obviously people have been doing these kinds of studies for many, many years, is that how much of it is it the need to drive them down to a negative MRD state, or how much is it the ability to actually do it and therefore reflect an intrinsic biology of the tumor? And I think it's probably a combination, but people have used this kind of data to justify hitting people with extremely aggressive therapy to get them down into a MRD negative state, when in fact, and I thought it was interesting that you found people who went into MRD after 3 cycles did the same as after 6, but I also noticed that the MRD after 3 cycles, the curves were a little bit higher. And that's the kind of thing you would see. And so I think it probably tells you a little bit about the tumor biology as well. So I just wanted to get your comments on that.
Yeah, I think that this is a multifactorial problem. So there is the biology of the disease, and there is also at least the effect of the drug. And therefore, we don't know. Maybe indeed there are patients who can go down even not to MRD negativity and remain there forever. So, I mean, as we have CLL patients who have 30,000 lymphocytes and they stay there for decades without any need of therapy. The problem is that we don't know before. So I always bring my experience because I had a study where patients were supposed to be enrolled if they were not achieving MRD negativity, and they could be enrolled in a study with lenalidomide of maintenance. And we had 2 patients who achieved MRD negativity, and we could not enroll them. And then one after 3 months, she completely she went back to the ceiling. Unfortunately, we saved her with ibrutinib. It's a case that I always show because the response was really dramatic, 10 to the minus, less than 10 to the minus 4 with FCR, and then it went up, 11Q, fine, but we could not predict that. Another patient happened a few weeks ago, exactly the same thing. So we could not do anything. We would not even have increased the type of therapy because she already achieved the MRD negativity. So that really means that the disease is intrinsically different. And probably the portion that is different is so small that we can destroy 99.9% of the leukemia, but still is there, and then it gets back in 3-6 months. So
So I think the key here is that this needs to be looked at, but I think Mark may have said this. When you have a very good drug like ibrutinib, which alone gives very rare MRD, by being able to drive more people down, you adding R or adding BR, are you really going to change the natural history? And I would suspect the data is going to probably show probably not.
especially in combination with chemotherapy, I'm
That's what
becoming
I'm
really
talking about.
skeptical. But
Right.
I can tell you something more. There are patients who can go down there, and we don't know. We don't have data, I think, yet. We can go down to partial response, and probably we can stop the drug, and they will
Yes.
remain there for a long time.
Right.
While instead others will know that as soon as we stop, 1 week later they are back
Absolutely.
to day 0. So again, also in that case, with these new drugs, we need to study biology of the disease because probably it's not an advantage for them, but for us, we can select the patient where we can stop the treatment after 1-2 years and with benefit of the patient.
Paolo, at what level of minimal residual disease do you think we can get to a point where we won't see it rebound? I hear Pete Hillman talking about 10 to the minus 8. He's also talking about the time to getting to MRD negativity and then holding them there for that amount of period and then stopping. What's your thoughts on that? Where do we go for a real cure?
We always discussed it with Pete. He has an approach, an informatic approach. So that's why I wanted to show. Indeed, I designed this picture. No, it's not here anymore. With the lines because of Peter. I don't think, again, that's a mathematical curve. So you can calculate how fast you go down, how fast you will come up. If everything is linear, this is not the case. Because again, if you have a clone that is 0.0%, you can go down very fast, and then it would take again very. Because the point is that I think that we have we are reasoning with the idea that we want to kill the last cell, but very likely with CLL and with this type of indolent lymphomas, it's not the very last cell that matters because the cells are controlled by the microenvironment, by the immune system. So we don't know, probably we can get to a certain level where you are not really cured, so you can still detect cells, but it's controlled because by the immune system that has not been destroyed by your chemotherapy because you didn't apply any more chemotherapy. So that's why I say it's a multifactorial thing. So probably we don't really know the value of getting 10 to the minus 2 without using chemotherapy. We don't know that because we never achieved that before.
So Paolo, there's interesting data that's coming out of Stanford that in post-allo treated patients who then get given ibrutinib, you see full chimerization come through. You see the ITK component of ibrutinib being an important, perhaps, component of that, or it's ibrutinib is resetting the microenvironment and the immune system. And Mikolos has shown that some of these patients see full chimerization, and you see patients get this rapid drop to MRD negativity with single agent ibrutinib, and he's now stopped patients who've been off therapy and don't reoccur or don't relapse. It seems to me that there's an intriguing piece there to the solution for how we cure, right, which is rectifying the immune system and reactivating it somehow could give you that path to cure. It's a question of what is that combination. I don't think allo is the approach for CLL, but it gives you a hint that there's something here with the immune system that if we could target it somehow, we truly could get to a curative point.
Definitely. In fact, we can learn from the allo because we learned that we don't need, so with the debulking, you don't need really to destroy every cell. You just have to bring it down to a level where the immune system then, so the transplant will control it. And then probably the cells will get rid of the leukemia, or they will just control. So as we were discussing before, I'm really puzzled by the fact that there is the p53 clone there, but if you don't touch it, the system controls it. So the good guys that are the majority can control the bad guys. It's when we get rid of the good guys. Yes, please. I'm chairing. I think I'm chairing. Oh, no, you are chairing. No, sorry. No.
Yeah. Well, as you know, the German group presented a paper in the last ASH meeting showing again that the negativity of a minimal residual disease could be a surrogate for PSF. And Michael Helk said to me that the EMA is about to accept this as an endpoint instead of PSF. Can you talk a little bit about that? Because if this is true, I think it will change a lot the speed of the results of the phase 2 studies.
What I showed before, the consultation last ended in June 2015. So we are, and they wrote a text we all agreed upon, and it's fair, it's reasonable. They didn't yet publish it. So, and I think that's why I showed that picture before. I really think that they are still concerned on extrapolating data from the immunochemotherapy experience into the biologicals era. So we don't know really what MRD negativity means with the new agent. What is also true is that publication would only suggest that MRD can be used as a surrogate for PFS, but that doesn't mean that you cannot test a drug or experiment a drug if you don't achieve MRD. So MRD should not be the endpoint for every trial, but it could be used as a surrogate endpoint in case you need it. But I think that's the major reason why they don't want to really push it so hard, because there is no proof that MRD has the same value with any therapy. Though, I mean, I also agree. I agree also with Michael. We show the data always around the world. We know that it's true that MRD is valuable regardless the therapy that you used, antibodies, FC, FCR, whatever. Yeah. We don't know with the new drugs. We don't know with the ABT-199, for example. That's a major concern. It's not for ibrutinib. We don't have that problem. With ABT-199, would you stop and register the drug because you see more MRD negativity?
But it's valid for venetoclax.
We don't know. We don't know. That's the reason. I think that
seems to be a longer response.
When it is shown, then they will say yes. Yeah. I'm sure that venetoclax is part of the reason why they are so reluctant, because you know.
Can we remind ourselves that we're talking about CLL, not of acute leukemias?
We are talking about CLL.
Because I mean, all this is fine, but I mean, we always tell everybody that MRD negativity should not be an endpoint
No, this is for clinical trials.
outside clinical trials.
This is
Now,
for
this is a key point. I mean, most patients, when they start treatment, are 75. So if you consider MRD negativity an endpoint, you have to put in balance how many patients you're going to kill with treatment to cure a few. So I think we have to keep this very focused. I mean, most CLL patients with chlorambucil can live the rest of their lives and die of old age. This is before the new drugs. So, I mean, this is obviously a key point, and this will come up again for the 17P and the P53. But I don't see any other clinical setting in Richter, but that's a transformation. But other patients where we have to go to MRD negativity, this is tough to convince. If we can do it easily with no toxicity, that will be fantastic, but that has still to be proven in medicine that that can occur. So I think we have to be very careful on that. If we can control the disease, keep it under control, and patients just live, that's fine. Except for some categories, and we are refining them much better. So now we already have a large, relatively large group of patients where we have to probably offer approaches where the endpoint should be MRD negative. For the others, it's questionable, very much. But we'll come back to that again. I mean, there are some categories that can even achieve that with the chemotherapy, and that's fine. So I think we have to be careful on this before we over-treat patients.
So the recommendation by EMA or by FDA would involve only the clinical trial.
Yeah.
So in clinical practice, there is no one who is even thinking of proposing MRD as an endpoint for your patient sitting in front of you. Definitely.
Yeah, absolutely.
Thank you for the clarification.
Yeah, that's very important.
It's only for clinical trials.
It has happened this, that people go home, and not here, but I mean other places, and they go and treat forever patients.
Yeah.
I remember with alemtuzumab this happening. Because the point of a regulatory agent is what you said, Paolo, that, I mean, this is an attempt to try to overcome the issue of long-term follow-up, because the MRD negative will be a short endpoint.
Of course.
That doesn't mean that you're benefiting patients necessarily.
The only thing that I would suggest, if one may plan about using MRD with patients in the future with studies, would be to try to decrease the intensity of treatment. So to see if achieving MRD, like with FCR, after 3 cycles, maybe so always to the advantage of the patient, not to increase. Okay.
May I do a technical question? But MRD is only in the blood.
Okay, that's a very
blood.
good question. Very good question.
When we study MRD, or when we would study MRD in acute leukemia, I learned that we have to isolate the cell, we sequencing the cell, and comparing the cell of remission with the cell of present or new relapse of leukemia, because the cell can change the characteristics, and then with this method we don't have the we don't assure that the same cell of the first MRD should be the same cell of the relapse.
Yeah. No, in CLL, the story is a little bit different, because indeed there is no change, or at least it's been not shown in the last 10-15 years. So the original clone remains, the relapsing clone remains identical to the original clone. That's why it's possible to do the flow, but also in terms of PCR, the immunoglobulin rearrangement doesn't change. But the point that you are bringing up is very important, because indeed we are testing the blood because it's easier. The blood is mirroring, reflecting the situation in the bone marrow in only 2/3 of the cases. So in 1/3 of the cases that are negative in the blood, if you go in the bone marrow, they are positive. So then we could move to the blood, and indeed the recommendation of the EMA suggests that the patient should be screened in the blood. Those who turn negative in the blood, then they should be confirmed in the bone marrow with an aspirate. Fine. We are going even farther, because we are referring to acute leukemia, that we are sure that the leukemia comes from the bone marrow. In the CLL, we are not sure. Actually, we think about the lymph nodes. So now the new question in MRD field is that should we go and do MRD in the lymph nodes? In which lymph node? Should we do a PET or so? The field is evolving somewhere we don't want to go.
In a non-palpable lymph node.
In
Well, if it's MRD, obviously, yeah.
So one thing that gets around this is NGS cell-free. That reflects the entire, that'll almost certainly reflect the
liquid
entire,
biopsy we are
the
going to hear
liquid
from you.
biopsy. So I think that, yes, when you're doing flow, absolutely. But once you start to move to cell-free systems, I think the whole calculus changes.
Of course, but then you can always think that going into another tissue, you could go even lower. So maybe. Okay.